Hypertension affects around 1 billion adults in the world. And while high blood pressure is the #1 reason for adults to finally go visit their primary care docs, not to mention the #1 reason for prescription drug use, the vast majority of these individuals are not adequately controlled. So, there she blows! We've reached the violent finale of Captain Ahab's obsessive quest to hunt down and kill Moby Dick. The elusive albino sperm whale who, on a previous whaling expedition, had taken one of Ahab's legs from the knee down. Ahab has driven the whaling ship Pequod across the Atlantic, around the Cape of Africa, on through the Indian Ocean, culminating in a final showdown with the beast himself, in the middle of the icy Pacific. Needless to say, tensions are running high. I mean, just check out that barometer. Here we can see the different stages of hypertension. If you haven't already heard, these definitions were recently changed in 2017. Normal blood pressure is anything less than 120 millimeters of mercury systolic and less than 80 millimeters of mercury diastolic. Anything higher than that, and we've got problems. From 120 to 129 millimeters of mercury systolic, with a normal diastolic blood pressure, we've entered the range of elevated blood pressure, formerly known as pre-hypertension. That's the area marked in green. These patients are destined to develop primary hypertension at some point in their lives, and this risk increases with increasing age. Management usually centers around lifestyle modification, including weight loss, exercise, a heart-healthy diet, decreasing salt intake, and avoiding excessive alcohol intake. Then we get into the red zone, the danger zone, if you will. And I will. Stage 1 hypertension is defined as a systolic blood pressure from 130 to 139 millimeters of mercury, or a diastolic blood pressure from 80 to 89 millimeters of mercury, while stage 2 is anything above that, meaning 140 or higher systolic, or 90 or higher diastolic. Once patients are persistently in these ranges, pharmacotherapy is typically started in addition to those lifestyle modification strategies we mentioned earlier. Check out our corresponding Sketchy Farm sketch for all the basics of hypertension treatment. For now, I want you to pay attention to that crack forming in the glass. This broken barometer heart is there to remind you that in all of these pressure ranges, including pre-hypertension, your patient is at increased risk for developing cardiovascular disease. This includes coronary artery disease, heart failure, stroke, and kidney disease, which we'll illustrate a little later. All right, this sketch is going to cover 2 categories of hypertension: primary or idiopathic hypertension versus secondary hypertension, caused by drugs and tumors and renal disease, all kinds of secondary stuff. Up on the primary deck, let's start our discussion with primary hypertension, which comprises over 90% of all cases. Primary hypertension was originally called essential hypertension, probably because they essentially had no idea what was going on. We have a few clues, though, and it all goes back to the normal physiological processes that contribute to blood pressure control. As you know, the heart is essentially an organic pump, forcing blood through a series of tubes. And just like in an actual series of pipes, pressure is the result of cardiac output pushing against systemic vascular resistance, or SVR. How much fluid you push out and how tight the pipes are determine the pressure. Since cardiac output is the product of stroke volume, the amount of blood squeezed with each heartbeat, multiplied by heart rate, you can think of blood pressure as stroke volume times heart rate times systemic vascular resistance. Specifically, this is equal to the average pressure over the entire cardiac cycle, or the mean arterial pressure. In this scene, stroke volume is the volume that fills the bucket with each pump. Heart rate is the heart watch, and SVR is represented by that tightly wound rope, evoking an image of the bands of smooth muscle that surround arterioles, the main resistant vessels of the body. Now, this conceptual physiologic equation is adequate for explaining short-term blood pressure control, but long-term control is a little more complicated. For example, let's say I ligate a large artery. With one less path for blood to travel, the SVR abruptly increases, which, according to this equation, would lead to an increased pressure, right? The body is really good at getting back to baseline, however. See that carotid sinus pressure gauge? Peripheral baroreceptors communicate with the CNS and tell it to turn down the sympathetic transmission to the heart and vessels. This leads to decreased stroke volume and vascular resistance. On top of that, the kidney turns down the renin-angiotensin-aldosterone system. Less angiotensin II floating around means less vascular resistance, while decreasing aldosterone activity promotes natriuresis and volume loss. For a more in-depth look at the RAS system, check out our Sketchy Farm ACE inhibitor sketch. For now, we're just going to keep it simple and draw in our recurring renin rain umbrella. Other mechanisms are at work as well, including fluid shifts and vasodilator release. But the key here is that blood pressure will return to normal within a few days. Yep, we're back at equilibrium. So, if the body is so good at controlling blood pressure, how does chronic hypertension come about? Well, after these short-term pressure control mechanisms have done their job, long-term pressure regulation takes over. To emphasize long-term, we've drawn in a grandfather clock, a recurring symbol for chronic conditions. Long-term control is achieved by the kidneys, which have a built-in mechanism called pressure natriuresis. Turn up the pressure, and the kidney turns up the sodium and water excretion to bring total body volume down. This is illustrated by the deckhand, using the pressure inside the nephron pump to clean the deck. Notice the water and salty sodium peanuts getting excreted. That's natriuresis. Imagine that the kidney has a set point, kind of like a thermostat. At your baseline blood pressure, your kidney has a set rate of sodium and water excretion. Change the pressure in the system, and pressure natriuresis adjusts accordingly, until we've dropped enough volume to get back to baseline pressure. In the setting of essential hypertension, however, the thermostat is broken. Take a look at the other hose. See how the natriuresis is lagging behind? It's thought that the pathogenesis of essential hypertension centers around kidney dysfunction, either from genetic factors or other mysterious idiopathic causes. Individuals with essential hypertension have kidneys that either don't excrete sodium very well or reabsorb too much of it. Either way, natriuresis is impaired. The kidney then is all like, screw blood pressure. I need to maintain normal salt and water excretion. So the pressure rises a little bit. And the kidney gets back to a salt and water excretion rate that's balanced by dietary intake. In other words, pressure natriuresis gets a new set point. At a higher baseline blood pressure, glomerulotubular balance and natriuresis is maintained. In addition to intrinsic kidney dysfunction, neurohormonal mechanisms might also play a role in resetting that pressure natriuresis set point. This includes chronic sympathetic nervous system activation, illustrated by Pip here, as his sympathetic fight-or-flight reflexes start to take over. Now, the sympathetic nervous system is great for short-term modulation of blood pressure. During exercise, for example, it allows you to immediately raise blood pressure by increasing heart rate, increasing contractility, and constricting vessels. Essential hypertension, however, is all about the long-term consequences. And it's easy to forget, but sympathetic nerves directly connect to the kidney as well. Excessive activation of these nerves causes sodium retention, increased renin secretion, and impaired pressure natriuresis. See how he holds on to those salty sodium peanuts as he runs for his life? Remember, if the kidney's sodium excretion mechanisms are impaired, pressure is allowed to increase in order to preserve natriuresis. We don't really know why the kidney starts to mishandle water and sodium transport, but numerous genetic and environmental factors are thought to contribute, especially age. I mean, just look at Captain Ahab's haggard and aged complexion, weathered from years of torment. Believe it or not, more than 70% of the U.S. population will meet the definition of hypertension by age 60. Hypertension in the elderly most commonly presents as isolated systolic hypertension, which is exactly what it sounds like. The systolic pressure reaches hypertensive levels, while the diastolic pressure remains below 90. At Sketchy, events that occur during systole are represented by a systolic champagne spray. Yup, even the old dude isolated in the brig is celebrating the whale's imminent demise. Though, spoiler alert, pretty much everyone on board is about to sink to a premature watery grave. In the setting of isolated systolic hypertension, large arteries, including the aorta, start to lose their elasticity and compliance. Hence the torn compliance document, originally there to remind the crew of which whale species are off limits to hunters. But I mean, Come on. There's no stopping a seasoned whaler from craving that noggin full of sweet, sweet spermaceti goo. There's as much as 1,900 liters of the stuff inside the head of a single sperm whale, in fact. Oh man, just think of how many candles you could make. Ugh, and don't even get me started on ointments. I just want to rub that sperm whale all over myself. Atherosclerosis, in addition to normal aging, leads to the accumulation of arterial calcium and collagen, as well as the degradation of arterial elastin. Now that the wall of the aorta is stiffer, it reflects more of the pressure waves that roll by, increasing peak systolic pressure without much change in the diastolic pressure. Systolic pressure rises while diastolic pressure drops as age increases. This is measured as an increased pulse pressure, as highlighted here by the increased gap in the bars. The top bar represents a systolic pressure tracing, while the bottom bar is meant to depict diastolic. All right, let's head back over to Ahab, who also embodies our next major risk factor for essential hypertension. For reasons that aren't entirely clear, hypertension disproportionately affects Black patients. In fact, hypertension occurs earlier, is more severe, and does more damage in this patient population. The rest of the risk factors are embodied by Starbuck, Ahab's first mate: obesity, high sodium intake, lack of physical activity, and excessive alcohol intake. The first step in treating any patient with hypertension is to discuss lifestyle modification in order to minimize these factors, especially that alcohol. Wasn't Starbuck a Quaker? Also, take a look at the photo Starbuck always carries with him, a portrait of his family back home in Nantucket. It's there to remind you of family history. Genetics actually plays a large role in the development and progression of hypertension. If one of your parents has hypertension, you're about twice as likely to develop it yourself. All kinds of gene mutations have been implicated, including those involved in angiotensin and aldosterone activity, sodium channel function, and smooth muscle cell growth. And that's it for primary hypertension. Let's head over to the second deck, where we'll focus on secondary hypertension. Though it accounts for a small minority of cases, secondary hypertension has an incredibly diverse number of causes. One of the most common is renovascular hypertension, which is caused by reduced renal perfusion due to stenosis of a main renal artery, depicted here by that stenosed arterial rigging. With reduced perfusion, the kidney upregulates renin production. And you know the rest of the story. Angiotensin II causes vasoconstriction, aldosterone causes salt and water retention, and hello, hypertension. In fact, these patients will classically present with severe hypertension that's resistant to treatment. See how gunky that guy looks? The usual cause of stenosis is an atheromatous plaque, and in many patients, there's a corresponding history of coronary artery disease or peripheral artery disease. Another funky pathology that could be at work here is fibromuscular dysplasia, embodied by this very muscular and displeased lady. Fibromuscular dysplasia is an idiopathic, non-inflammatory, and non-atherosclerotic disorder that results in fibrosis and hyperplasia of the arterial wall, usually the muscular media layer, hence the collagen shark tattoo on that intimidating muscular bicep. The vast majority of adult patients with this disease are female, while in children it affects both sexes pretty equally. The renal arteries are commonly involved, as are the carotid and vertebral arteries. On angiography, look for that classic string of beads appearance, caused by alternating areas of fibromuscular change and aneurysm. We'll add some beads going down her neck as well, to remind you of carotid involvement leading to symptoms of headache, pulsatile tinnitus, and even neck pain. These patients are also at risk for TIA and ischemic stroke. When assessing your patient with possible renovascular hypertension, whip out that stethoscope and listen for some arterial bruits. Bruits are caused by turbulent flow and can be heard by placing your stethoscope directly over the affected artery. In this case, a renal artery in the abdomen. Though keep in mind that in the setting of fibromuscular dysplasia, bruits can be found in the carotids as well. Over time, the poorly perfused kidney suffers from a lack of oxygen and nutrients, which can lead to atrophy. On imaging and gross pathology, this will show up as an asymmetry in kidney sizes. One normal kidney, and one sad, shriveled one. And finally, one last clue that your patient has renal artery stenosis, and not just some regular run-of-the-mill essential hypertension, is an adverse response to ACE inhibitor therapy. As I mentioned earlier, the kidney downstream from the stenotic lesion upregulates renin production in the face of reduced perfusion. Renin turns angiotensin to angiotensin 1, and in the lungs, angiotensin 1 is converted to angiotensin 2 with the help of ACE. Angiotensin 2 plays a critical role in maintaining GFR in low perfusion states by constricting efferent arterioles. In other words, that kidney distal to the stenosis is relying on that extra angiotensin 2 for survival. Throw an ACE inhibitor into the mix, and kidney function deteriorates, resulting in a persistent elevation in creatinine a few days after starting therapy. So to remind you that ACE inhibitors are a no-no, we've tipped over this poker table, scattering ACEs into the sea. The passed out guy wearing our recurring angiotensin 2 arterial suspenders symbolizes decreased angiotensin production, while those spilled coffee grounds represent the ensuing decrease in GFR. Grounds filtration rate, if you will. Next on our list of disorders associated with secondary hypertension is acute and chronic renal disease. This includes anything from acute glomerulonephritis to diabetic nephropathy and chronic kidney disease. Depending on whether the pathology affects the vessels or the glomeruli and nephrons themselves, the pathogenesis of hypertension varies. It usually involves a combination of decreased sodium excretion and increased renin production. Throughout the renal pathology unit, look for those steaming ears. We'll bring back this symbol whenever we want to emphasize hypertension as a common finding. Aw, cheer up there, baby Genghis. You'll get your turn. Over at the spermaceti processing area, I want to also remind you that several classes of drugs can cause secondary hypertension, including OCPs, the most common cause of hypertension in young women, NSAIDs, corticosteroids, and illegal drugs such as cocaine and methamphetamines. Check out our corresponding sketches on these drugs in Sketchy Farm for more info. Next up is hyperaldosteronism. Since aldosterone is a mineral corticoid hormone essential for sodium conservation by the kidney, it's symbolized by salty mineral deposits, like these on the side of the deck. Too much aldosterone means too much sodium and fluid reabsorption, leading to hypertension and hypokalemia. Keep in mind that aldosterone preserves sodium at the expense of potassium. Check out our journey to the center of the adrenal sketch for all the salty deets. We're going to finish off secondary hypertension with obstructive sleep apnea. While the specific pathophysiology is not fully understood, we do know that the excess catecholamines produced as a result of the lack of restful sleep in OSA can keep blood pressures elevated during sleep as well as daytime hours. Now, this is by no means an exhaustive list. Other causes of secondary hypertension include Cushing's disease, hyperparathyroidism, hyperthyroidism, hypothyroidism, pregnancy, all kinds of stuff. Don't worry, this will all be covered in later sketches. To wrap up this sketch, we're going face to face with the cetacean beast himself, surfacing on the port bow. Because of its insidious nature, hypertension can go untreated for years. It may be all fine and dandy at the beginning, but under the surface, the consequences of chronic untreated hypertension can be devastating. Let's start with the heart. Just imagine pumping against all that pressure with each beat, over and over. Hypertension is an example of increased afterload. To compensate for this pressure overload, the heart undergoes hypertrophy, usually concentric hypertrophy. That means the myocytes are adding on top of each other in parallel, causing an increase in myocardium thickness. Just think of the layers upon layers of shell spiraling inside this concentric conch. At this point, you're well on your way to heart failure. Hypertension is also the #1 cause of aortic dissection, which can be incredibly lethal. Furthermore, hypertension is a major contributing factor to the development of atherosclerosis and aneurysms. In both cases, pressure causes damage to the vessel wall, setting off a series of detrimental changes. So, in light of all this athromatous gunk accumulating in the arteries, it's not hard to imagine that hypertension is the leading risk factor for heart attack and ischemic stroke. Heart attack, symbolized by that broken heartstring, and stroke, represented by that black stroke on the sailor's head. We're talking hemorrhagic stroke too. Hypertension is the most important risk factor for the development of intracerebral hemorrhage. And just take a look at that retinal life preserver. It's meant to evoke an image of the changes seen in hypertensive retinopathy. On fundoscopy, expect to see retinal hemorrhages, exudates, and even papilledema. represented by that bulging papilledema inflation port. One of the most damaging consequences of untreated hypertension is nephrosclerosis. A vicious cycle ensues. Kidney injury leads to kidney dysfunction, which worsens hypertension, causing more kidney damage, causing, you guessed it, more dysfunction. Two unique presentations of hypertension are worth mentioning here: hypertensive urgency and hypertensive emergency. Hypertensive urgency is the presence of severe hypertension, typically a blood pressure higher than 180 over 120. A systolic of 180 is symbolized by the 180 degrees protractor, while a diastolic of 120 is symbolized by the 12-inch ruler. Prematurely measuring your spermaceti before the whale is slain. Come on, Braden. This is like whaling 101. The goal in treatment of hypertensive urgency is to lower the blood pressure gradually, investigate the cause of hypertension, and then reverse it. Even worse is hypertensive emergency. It was previously referred to as malignant hypertension because of the poor prognosis it carried prior to the development of modern antihypertensive drugs. All the parameters are the same. You need severe hypertension, typically greater than 180 over 120. This time, however, you've got end organ damage. Some of the most common symptoms of hypertensive emergency include encephalopathy, intracranial hypertension, papilledema, AKI, flash pulmonary edema, and even decompensated heart failure. The most commonly affected organs are the kidneys, eyes, and intestines. You know, the organs that receive the most blood in the body. Again, blood pressure should be lowered gradually, since lowering it too fast can create a sort of relative hypotension that can lead to heart attack or stroke because the patient's blood pressure autoregulatory mechanisms are used to such high pressures. On histology, chronic hypertension causes several characteristic changes in arteries. Besides predisposing to atherosclerosis and aneurysm, all this pressure can lead to hyaline arteriolosclerosis, embodied by this arterial snake covered in sclerotic scales. Notice that on the side of the hole, we've recreated the vessel wall. The purple is the intima, the red designates the smooth muscle of the media, and the brown marks the externa. Hyaline arteriolosclerosis is caused by hypertensive damage to the endothelial cells of the intima, allowing plasma proteins to extravasate into the media. In addition, the chronic hemodynamic stress on the vessel wall stimulates endothelial cells to produce excess extracellular matrix. Under the microscope, vessel walls will appear thickened due to a homogeneous layer of pink hyaline material within the media, just like this homogeneous accumulation of pink algae. The end result is a thickened vessel wall, a narrowed lumen, and a blood vessel that is much less capable of delivering adequate blood flow to its target organ. These changes can be especially damaging to renal arteries, resulting in nephrosclerosis, which is characterized by diffuse glomerular scarring. This is similar to the hyaline arteriosclerosis that we saw in diabetic patients at the nephrotic wall of Wallace. Instead of pressure causing the initial endothelial damage, however, it was hyperglycemia. Chronic severe hypertension and hypertensive emergency can also lead to an even more advanced histological finding called hyperplastic arteriolosclerosis. In hyperplastic arteriolosclerosis, smooth muscle hypertrophy and reduplication of the vessel endothelial basement membrane cause concentric thickening of the vessel, and eventually luminal obstruction. The result is a characteristic onion skin appearance from the repeated circular lamination process. In acute hypertensive emergency, these histologic changes may also be accompanied by fibrinoid necrosis of the vessel walls, also known as necrotizing arteriolitis. For the defining characteristics of fibrinoid necrosis, take a look at the cool Rasta dreadlocks hat being worn by the captain of the Rachel. That ring of pink gunk is exactly what you think it is. Greasy dreadlock residue. A fitting representation of the pink proteinaceous ring that develops inside the vessel wall. An accumulation of necrotic cell debris and fibrin. We've even added a few skull beads to remind you that this is necrosis we're talking about here. These changes are particularly prominent in renal arteries. Well, that's it for hypertension. For more info on the specific drugs used to treat high blood pressure, and there are quite a few, check out our primary hypertension and hypertensive emergency sketchy farm sketch.